Thank you for that tremendous introduction, Derek. I've been given this topic, low rectal anastomosis, and the paper was this paper by a great hero of mine, and many of you, I think, certainly the colorectal people in the audience, John Gallagher. And it was basically about sphincter preservation, which is very, very close to my heart for personal and professional reasons. That's the man, a man you should have never have gone for a drive with because he was the most dangerous driver of a car you'd have ever wished to see, but a remarkable individual. And talking about writing, his writing style was absolutely fantastic. He had this Socratic ability to dissect a topic, but he would go on quite a lot, editor, and you would have had a field day, I'm sure. So this was the situation. The rectum, and it's no different really now, divided up into its three components. In those days, 1964, when this paper was published by Gallagher, this was the operation that was performed for high tumours, an anterior resection, hand anastomosis. This was described by Dixon from the Mayo Clinic. But most patients, of course, had an abdominoperineal excision and a permanent colostomy. And in fact, that is one of Gallagher's excised specimens. He always used to, just out of interest, make sure the pathologist drew the specimen and put the lymph nodes on. I always thought that was impressive. But so it was the argument really at that time in the 60s was what happens in the mid-rectum and how do you, not the lower rectum, but the mid-rectum. And that was the argument at the time. And you can see 7.5 to 11 centimeters was the target area. And at that time, it was very important to note that everybody was told that they must resect distally at least 5 centimeters to get a clear margin. And that was the operation. Now, Gallagher was not an innovator. He would be the first to say that, but he was a great trialist. And this, in fact, was the Cuttet, or Turnbull to Turnbull Cuttet procedure, which was an eversion technique. And that was what this paper was all about. The problem with eversion techniques is you pull on the anal sphincter, you damage the pudendal nerve, you damage the sphincter, and the results were never very, very good, actually, because, in my view, of that. And that was actually reported and hidden within the paper. Gallagher then realized that from that paper, actually, and was very intrigued with this, which was, of course, the Russian SPTU gun, which there's another interesting story about that. I won't go into that, but that was brought over from the Moscow Proctological Clinic by a chap called Fain. As I say, it's a long story. You used to have to load the staples into this, and some of you are nodding in the audience. I think you probably recollect those days, and that was the staple that was used. And Gallagher produced this paper 10 years later, even longer from that previous paper, showing how actually, even in mid-rectal cancers, and he was gradually creeping down, of course, getting lower and lower, but still in the mid-rectum. And he pointed out that previous techniques had used traction, transanal techniques, etc. And this was the way to go because it preserved the anal sphincter intact. And that's a very, very important concept. And you'll notice the president of this association was a junior colleague at the time. And of course, we moved on with modern stapling instruments now and colo pouches, etc. But to get there, we had to look at the pathology of this. This was a study that I did in Leeds, looking at distal margin, and we now know you can quite comfortably reduce that margin to probably just 1 centimeter, or in certain cases even less. That is not the most important aspect of spread. And we also now know all about the circumferential spread, of course. Phil Quirk and I did a study in Leeds which showed this and how important it was and essential to remove all of this. So as long as you do a TME together with a high tie, then you can resect that distal margin quite close to the tumour to preserve the sphincter. I won't go into that paper. And of course, we've moved on with the Holy Plane, the whole concept of TME with Bill Heald. So the situation now is that incredible progress has been made in the concepts sphincter preservation, stimulated by that work, not just by Gallagher, but of course by Alan Parks, who really was an innovator. So between 1980, I would say, and 2010, the present time, 80% of stomas, if you had a rectal cancer, 80% of patients underwent a colostomy in 1980s approximately, and nowadays that figure's about 30% internationally. We were interested in this, of course, when we looked at this recently, and in the UK it's even lower than that. It's at about 20% of all comers with rectal carcinoma. And what's interesting, though, if you look at the States, the figure is a lot higher. The figure of permanent stoma formation is a lot higher, at about, as you can see, about 50%. So why that? We could argue that. I think that's due to subspecialization. So in the line of that Gallagher paper, as it were, I worked for him, actually. The nicest thing he ever said to me was that I wasn't inadequate. You know, that was Tenger's great praise. He was a perfect gentleman, but not great with the compliments. But there we are. But this has always stimulated. All that work that I was observing at that time in Leeds stimulated us and has kept me on track, actually. And we've recently asked this question: can we reduce even more now the number of permanent stomas by further technical development, particularly in the laparoscopic era? So really now what we're talking about, and I think everybody's talking about this area, the lower third. And of course there are major technical factors here when you're doing an ultra-low anterior resection, of course. The inability to achieve an adequate clearance, the safety of performing that anastomosis whilst preserving the sphincter integrity without doing any form of pull-throughs type of procedures. And of course now we're in the laparoscopic era, and all the experienced laparoscopic colorectal surgeons accept that it is extremely difficult to apply a stapler transversely to that distal rectum very low down in the pelvis. Various notable colorectal surgeons in the audience are nodding and appreciate that. And why is that, of course? It's because you've got various anatomical abnormalities, particularly in males with narrow pelvises. The male pelvis is narrower, it's deeper, and poses real problems. So, okay, in a woman, average build, it's much easier to do an ultra-low anterior resection using a laparoscopic technique, but it isn't easy in a big male with a narrow pelvis. And this has been the conundrum for us over the last 20 years, I suppose. And these are the different approaches that have been tried, but of course they all damage the sphincter in one way or other. And I just put two recent techniques now. The intersphincteric technique, which is relatively, it was popularized by Schissel from Austria, and it's got its certain supporters. And this newer technique, which we've described, called the APPEAR technique, which employs the anterior perineal approach. And the intersphincteric approach, to get really very low down, you can see how it damages the sphincter. It must damage the sphincter, either the internal and indeed sometimes the external sphincter. So function can never be 100%. The internal sphincter is damaged inevitably by that intersphincteric approach. All of the rectum has to be sacrificed when you're doing that, because you're doing a transanal technique and you can't see the pathology as easily using that intersphincteric technique. So we came up with this concept of the rectal no man's land. As you appreciate, my first name is Norman. Play on words, perhaps, you might think, for self-aggrandizement. I decided, being the London correspondent to the BJS, as I was once called by David Carter, that I would send this into the journal, and Derek kindly published it. But the rectal no man's is a concept, really, and it's this area of the most distal part of the rectum which is enclosed by the pelvic musculature. It's that area that you think, it's that area where you go down from above, you think you're leaving 4 or 5 centimeters of rectum behind, or even less. You're very pleased with yourself. but in fact you're often leaving 10, 12, even 13 centimetres. And you can see that this is the area enclosed within the pelvic musculature. And from the junction of the superior border of the levator ani to the superior border of the external anal sphincter. And it varies, as you can see, in its length, depending, as I said at the beginning, depending on the build of the patient, from 4 to 13 centimetres in our, so if you put a pelvic pouch, for instance, on the top of this, what you're really doing, of course, is a pouch rectal anastomosis, and that's defeating the object. So this technique that we've called the appear technique can exploit this rectal no man's land, and by going in anteriorly, and that's the plane. I'm just going to show you a quick video. The appear procedure is used in combination with a standard open or laparoscopic abdominal approach. The abdominal operator fully mobilizes the left colon and performs the rectal mobilization and total mesorectal excision as low in the pelvis as possible. He can then transect the rectosigmoid junction to aid in further rectal dissection and in averting the rectum. If safe distal rectal resection is prevented by pelvic anatomical considerations, the anterior perineal approach can be utilized. An extrasphincteric convex incision is made in the anterior perineum to access and dissect the distal rectum within the pelvic floor. Anteriorly, this plane is developed until the plane created by the abdominal operator is reached. After the rectum has been fully mobilized both laterally and posteriorly within the pelvic floor, the rectum can be averted through the perineal wound. Under direct vision, the rectum can be transected at the desired level using a linear transverse stapler. The previously mobilized left colon is then delivered through the perineal wound and, if possible, a colopouch fashioned. The specially designed extra-long anvil of an appropriately sized compact CS circular stapling instrument is secured within the proximal colon with a purse string suture. The extended shaft of the anvil is grasped and guided through a previously created enterotomy in the anorectal stump so that it emerges through the anus. The trocar of the stapling instrument is fully extended and docked with the anvil extracorporally. The stapler is then carefully closed and advanced transanally, ensuring no extraneous tissue is caught in the device. Once the stapler is fired, the anastomotic integrity should be thoroughly assessed prior to wound closure. So that, of course, it doesn't look really like that. This is what it really looks like. And that's the rectum fully mobilized through the anterior perineal plane. You see what, it really is quite an amazing view, because there is the sphincter there. You're really right down to there. There's the tumour, so you can really remove at any point you wish and get the appropriate clearance. So I think that could radically change our hope practice by retaining far more sphincters. Now, I could go on, and I'm bore you silly with all the results, but this is just the pilot case, pilot series, I should say, 36 cases. But I just want to show you just this result, really. You can see these are patients that really, with a variety of difficult pathologies, often referred, some of them who already had permanent stomas in inverted commas. And they're a hodgepodge, a heterogeneous group of patients. But even in this group, we're able to save the sphincter in 50% of them with pretty good function. So I think that this sort of work has been stimulated by that early work by Gallagher and, as I say, by Alan Parks. And I do believe that, of course, with appropriate studying, etc., because it requires a much bigger trial, and we're running a multi-centre trial at the present time, that we should be able to reduce the incidence of permanent stomas, in my view, down to about 5–10%. Take that figure from 30% down to 5–10%. Thank you.